I'm going to speak today about drug eruptions in children, and this is a very large topic to cover. So because of Dr. S.'s lectures on seizures in children, I will have a special focus, especially related to the anti-epileptic drugs. Why do drug eruptions occur in children at all? I wanted to address this with you first. Well, there are a number of different factors that contribute to this challenge. First, it has to do with the molecular weight of a drug, the chemical structure, and I will focus very much on that with you today. The metabolism of the drug also plays a very key role, and the metabolites generated by the drug as it is metabolized, as well as drug interruptions. I'm going to cover every aspect of this throughout this lecture. In addition, there are important genetic factors that contribute to drug eruptions, particularly when we deal with certain anti-epileptic medications. And then the accumulation of toxic metabolites can lead to some of the most serious and worrisome skin conditions that a dermatologist will manage. I wanted to mention that there are pharmacokinetic changes that can lead to drug eruptions, particularly relative to absorption and distribution and elimination of any drug prescribed in a patient. There are also pharmacodynamic changes in synergism and antagonism at the site of action of a drug that can lead to drug eruptions. Now, again, I'm going to focus on anti-epileptic medications because I know Dr. S is going to give you several lectures on epilepsy, and I thought this would blend very nicely in the context of today's overall discussions. We recognize that in anti-epileptic prescriptions, about 16% of patients who receive these drugs do wind up with a drug eruption. Some of these are severe, and that can occur in 1 in 10,000 exposures. These are of great concern to all of us. And most of the very severe cutaneous eruptions will occur within the first 2 months of therapy. But that's not always the case, but I think you should be aware of that time course. So we're going to talk about first-line anti-epileptic medications. We'll talk about phenytoin, phenobarbital, carbamazepine, and I've listed the generic and brand names that we use in the United States. We have talked about the fact that these are some of the most challenging drug eruptions that we actually see, and I'll explain to you and give you photographs to understand why we consider this so significant. Now, epilepsy. We know that about 70% of children can achieve very good control with oral medications alone. And therefore, this discussion is very germane to that population. So what is the history of epilepsy as we know it in medicine? Well, actually, seizures have been described as far back as 1067 BC in the Babylonian tablets. So this is not a new crisis that we faced in patient management. It's a very old one indeed. And modern drug treatment, at least what I could find, actually began with potassium bromide, which was published in The Lancet back in 1857. So some of our therapies are very old indeed. Now again, the drugs most likely to cause an eruption in a patient prescribed these for seizures are carbamazepine, phenobarbital, phenytoin, and lamotrigine. And there is a common portion of the chemistry of each of these agents that leads to the commonality of the drug eruptions, and I'm going to visually display this for you. The reason these drugs tend to cause reactions that deal with the skin is the fact that they are all aromatic compounds, and the aromatic ring is indeed felt to be the significant portion of this molecular structure that leads to these types of rashes. So again, the aromatic anticonvulsants in the most common form of anticonvulsant agent, carbamazepine, phenobarbital, phenytoin, and lamotrigine. So here I've illustrated for you what phenobarbital looks like. Look carefully at this aromatic ring because it really is the signature finding here that leads to the discussion. And I've again highlighted the fact that we have this beautiful aromatic ring on the lower left. So this is typically used first line, particularly in children under 2 years of age in the United States. It was introduced originally in 1938 as an anti-seizure medicine, but had been used as a sedative as early as 1912. So this is a very old medicine. It did not go through some of the rigors that the Food and Drug Administration in the United States requires today for drug development, because it came of age at a time before those requirements were in place. Moving on now to phenytoin, in the United States often called Dilantin. This is also an aromatic compound, and indeed it has 2 aromatic rings, thus making it particularly apropos to causing a drug eruption. So if we look at these aromatic rings, we're beginning to get the theme that I discussed with you in my earlier slides. Dermatologic events occur in 5 to 10% of all patients who receive phenytoin, and so it's not a minor challenge to face as you use this medication. What happens with these aromatic anticonvulsant agents is that some of them are actually converted to toxic arene oxide metabolites, and these metabolites are these are actually metabolized by enzymes such as epoxide hydroxylase. And some patients have deficiencies or aberrations of this enzyme, and as a result cannot handle these metabolites very effectively. These metabolites tend to accumulate, and they actually lead to direct injury in the cellular level as well as cellular death. And this is represented most clearly in the skin on visual exam, but it can occur in the liver, in the kidneys, and in other organ systems as well. We also know that toxic arene oxide metabolites alter cytochrome P450 enzymes amino acid structure, and this contributes to some of the toxicity. And thus we get an autoimmune problem in organs that produce cytochrome P450. This includes, as I mentioned, the liver, the skin, the kidneys, the stomach, the GI tract, and the lungs. So virtually everyone who's presenting in this room can face this challenge if they treat a patient with certain aromatic anticonvulsant agents. Now we know that cell damage occurs, and we recognize that these metabolites form a hapten, which elicits this immune response. So what is a hapten? Let's go back to our medical school training. This is actually a parcel antigen that's actually an incomplete antigen that alone cannot produce antibodies, but it can be covalently linked to a protein and then trigger antibody production, which is not good. Let me give you an example of this that is particularly meaningful in the population of patients that I treat. There's something called EMPACT syndrome, E-M-P-A-C-T, and there have been a number of reviews in the literature. What does this stand for? Erythema multiforme, phenytoin, and cranioradiation therapy syndrome. So if you have a child who's undergone brain surgery and then they get a certain anti-epileptic medication, they can wind up with this, which is toxic epidermal necrolysis. And I cannot tell you what it's like to be the pediatric dermatologist when the child has undergone a very successful brain surgery and the child dies because of toxic epidermal necrolysis. Heart-wrenching, heartbreaking for the parents, very difficult. This is the most serious skin condition that any dermatologist can face, and nothing is worse than talking to parents again after a successful brain operation with catastrophic dermatologic impact for that patient. Now we know that phenytoin can have some more minor problems with patients treated with this drug. Certain hyperpigmentation that persists. They can often have extreme hair growth that's on the face and extremities, and this may indeed be considered irreversible once triggered. We can also see gingival hypertrophy. Note that this occurs in only patients who actually have teeth, because you must have plaque on the teeth for gingival hypertrophy to occur. These patients can develop coarse facial features and even osteoporosis. We'll go on now to an even more serious medication in some cases of patients who take it. I want to talk with you about lamotrigine, which, as you notice, has 2 aromatic rings. Lamotrigine is actually very well absorbed and 100% bioavailable when taken. both phenytoin and carbamazepine actually reduce lamotrigine levels, and this must be something we are aware of, and valproate actually increases lamotrigine levels by enzyme inhibition, and this is well known and often used when increasing the therapy of valproate slowly in the setting of lamotrigine therapy. So if lamotrigine is actually given with valproic acid, and this is common in the United States, the drug eruption is actually more likely, especially if dose escalation is actually exceeded. With lamotrigine, about 10% of patients will develop both erythema and maculopapular eruption, the most common form of drug eruption we see. The eruption typically occurs between weeks 2 and 8 of therapy. Now, I want you to be aware that of all the drugs currently on the market, at least in the United States, lamotrigine represents the single drug that causes the worst drug eruptions in the most pediatric patients that we manage. These eruptions can indeed be life-threatening in 1 out of 150 children who receive lamotrigine, and this occurs more often in children than patients in the adult realm who are treated with lamotrigine. Life-threatening eruptions, 1 in 100 to 1 in 50, and 3 in 1,000 adult patients, life-threatening eruptions. Here's a patient, another patient with more mild toxic epidermal necrolysis. You can see full thickness necrosis of the skin, and this child was managed in a pediatric burn unit. Now, in the United States, lamotrigine is currently not indicated for children under the age of 16 years unless they have Lennox-Gastaut form of seizures. About 1% of all patients treated with lamotrigine actually develop Stevens-Johnson syndrome or toxic epidermal necrolysis. They also get angioedema and associated pruritus. Now, how can we actually reduce the risk of the eruption? Well, we want to recommend that you initiate the dose at the lowest possible dose and increase it slowly. It's not 100% effective, but it can be helpful. Hypersensitivity reactions that can occur can be fatal. These patients get, unfortunately, multi-organ dysfunction with hepatic abnormalities and disseminated intravascular coagulation. Earliest manifestations, watch these patients for fever and lymphadenopathy. Indeed, this could mimic a viral infection, but in the setting of LAMICTAL, careful attention must be taken. We talked about starting the drug at the lowest possible dose. That is key. We also have mentioned predictors of lamotrigine likelihood of getting an eruption. If the patient has been on another aromatic anticonvulsant agent, their risk of taking lamotrigine and having an eruption themselves is more likely. Children less than 13 are unfortunately even more likely to develop a rash, particularly a serious rash. In a chart review of over 988 patients, about 5.7% of all patients treated with lamotrigine developed a rash, and 3.9% actually had to discontinue the eruption because of that rash. So what are the comorbidities that increase the likelihood of the seriousness of lamotrigine rash developing? Well, if they're co-treated with valproic acid, I've covered that before. If the patient is female, we don't know why that makes them more likely to have it. If the patient is being treated for static encephalopathy, or if they have drop or astatic seizures. Now, this is a patient that I treated in the intensive care unit who developed widespread erythema and Stevens-Johnson syndrome as a function of taking lamotrigine. She's a patient who originally heralded from Mexico, and there is a genetic predisposition in the Mexican population that also makes their risk greater. Now, allegedly, if the patients have increased weight, they have decreased risk factors, but that patient was clearly overweight, and this was not protective in her case. Now, we know that there are certain Indian patients who actually also, because of genetic predisposition, are more likely to develop the lamotrigine rash. I'm going to go on now to valproic acid, in the United States known as DEPAKOTE. This is a different type of anti-epileptic agent, and you can see that there is no aromatic ring here, so it's a different class. Originally, valproic acid was found out to be an anti-seizure medicine because it served as a vehicle and part of the placebo in a clinical trial for a seizure med, but its efficacy was recognized. This particular medicine also inhibits the cytochrome P450 system. The adverse cutaneous reactions include alopecia, excessive sweating, they can get a photosensitivity, and they can also develop itching. They can indeed get erythema multiforme and Stevens-Johnson, even though this is not considered an aromatic anti-epileptic agent. You need to be aware that valproic acid can also lead to pancreatitis, idiosyncratic fatal hepatic necrosis, and it has the highest risk of fetal abnormalities if prescribed during pregnancy. This was a young lady who developed horrible pancreatitis while taking valproic acid, and she suffered terribly as a function of that consequence. Adverse hepatic reactions, these can also occur after general anesthesia, and if the patient should happen to have a mitochondrial mutation, these particular patients are uniquely susceptible to the adverse events caused by valproic acid. Valproic acid also triples the half-life of lamotrigine, so you may have a greater risk of rashes there too. Going on to another aromatic agent, carbamazepine. This is clearly aromatic with 2 aromatic rings on each side of the molecular structure. Cutaneous side effects, oral ulcerations, unusual bruising, urticaria, unfortunately also Stevens-Johnson syndrome, as well as photosensitivity. So this is a youngster who comes in completely denuded lips, erythema, classic Stevens-Johnson syndrome as a function of taking carbamazepine. It's the most common cause of toxic epidermal necrolysis in some series reported in the literature. Now, we are aware that in the last number of years, there have been certain HLA phenotypes that have been uniquely associated with drug eruptions. This is particularly true with phenytoin, where HLA B1502 and CYP2C9 genotypes are uniquely predisposed to developing drug eruptions from anti-epileptic drugs. The Han Chinese population carries some of these genetic phenomena more than other populations, and in the United States, if you are of Chinese descent, typically these markers are looked for before carbamazepine or phenytoin are actually prescribed to you. HLA-B1502 increases your risk for Stevens-Johnson syndrome in carbamazepine, phenytoin, as well as lamotrigine. So if that population happens to exist here in Jordan, and I don't know if it does, it is something to pay very close attention to. Now, our kids don't read the books, and I think most of you can recognize this kid does not have Chinese heritage, but he got a carbamazepine drug rash anyway. It wasn't one of the more serious ones, but we discontinued the medication and managed him with another drug. We are aware that there can be cross-sensitivity between phenytoin and carbamazepine. I want to put these 2 drugs up here so you can recognize the importance of the aromatic ring and understand the pharmacologic basis of some of these very important and critical drug eruptions. Why do some of these drug eruptions happen? We know that there are T cells that are upregulated, and these T cells then tend to attack many of the components that lead to the serious drug eruptions that occur. Now, in the more recently developed drug arena, we have a trileptal or oxycarbamazepine, but it also has aromatic rings and also can lead to drug eruptions. It can develop jaundice, easy bruising, hives, and a decreased sense of touch. It can have anaphylaxis as a side effect, increased sweating, and both forms of erythema multiforme. This is erythema multiforme, and I want to show you an even better close-up. You get these fixed target lesions, often on the palms and soles. These do not move, they often don't itch, and they stay for at least 7 days. I want to speak to you also about levetiracetam. We call it Keppra in the United States. This particular medication, at least in the United States, is not reported to have adverse cutaneous reactions. So it is a good alternative if you want to keep your dermatologist out of your patient's arena. I have to say, though, everything you read is not true, because here is my patient who got a cutaneous eruption that was indeed a vasculitis as a function of taking Keppra therapy. We took her off the drug. She did very well. So in conclusion, what I really want to be your take-home message today is the fact that many of the anti-epileptic drugs, while they help our patients greatly with seizure control, have the potential to cause cutaneous eruptions. These eruptions can range from mild and annoying eruptions to all the way to very serious, life-threatening eruptions for our patients. So we do want you to be aware as practicing physicians to avoid the aromatic anti-epileptic medications in those patients who are sensitive when this is considered a feasible realm for you to undertake. And I will close with that concept. Thank you.